So panelists with me are Dr. Rajeev, he is a medical oncologist, Dr. Nidhi Patni from radiation oncologist, Dr. Amol Akhade, medical oncologist, Dr. Nitin and Dr. Suresh are the surgical oncologists with me on the panel. I hope everybody has joined.
Yeah, ma'am.
Yes,
Yeah.
madam.
Okay. So our panel discussion is on the operable breast cancer, whether to go ahead with surgery or with neoadjuvant chemotherapy. So I'll begin with this case. So I have a 49-year-old premenopausal lady who has no comorbidity and she's been diagnosed with CA left breast. On clinical examination, there is a 4 centimeter lump in the upper outer quadrant and a single lymph node in the left axilla, which is 1.5 centimeter and mobile. We did the biopsy first, and the biopsy revealed a grade 3 tumor, which is ER/PR negative and HER2 3 plus. So, how should we manage this patient? Should we go ahead with surgery first, or should we go ahead with neoadjuvant chemotherapy first? So, let me ask Dr. Nitin first. So, he's our surgical oncologist in the panel. So, Dr. Nitin, what would you like to do? Hello, is Dr. Nitin there?
Dr. Nitin, you need to unmute yourself. Madam, his internet got lost, I think. You need to
Okay.
carry on.
Yeah. Then Dr. Suresh, can I
Yeah,
request
ma'am.
you to take up
Yeah.
this question?
Looking to the case, I think it's a HER2 positive case.
Yeah.
So it goes into the high risk group.
Mhm.
So better to go neoadjuvant first in this case.
Okay. So is surgery an absolute contraindication in a HER2 positive?
No, not at all. Not at all.
Then why do you want
If you
to?
are if you are planning BCS, if you are planning BCS, and you want to give good results, and because considering the high risk because of HER2 positive, you can give uh, neoadjuvant chemotherapy. But if a
Suppose this
surgeon
patient,
wants to go for a surgery, he can uh, do upfront surgery also.
okay. So suppose the same tumor had a size of 2.5 centimeter and clinically there was no node palpable in the axilla. We see
Then surgery.
visible upfront.
Yeah,
Then,
upfront surgery.
so let me ask my medical oncologist, Dr. Rajeev, what would you like to do first in this case?
Yes, madam. Looking at the present data, I am audible, no?
Yeah, you're audible.
Yeah. Looking at the present data, I go with the neoadjuvant chemotherapy, even though it is a early breast operable, as even the surgical oncologist agreed, it is a high risk group. So we can see the pathological complete response. So it is better to go with the neoadjuvant with the complete HER2 dual blood.
Okay. Do we have Dr. Amol? Dr. Amol Akhade, are you there? Dr. Amol? I think he is not joined with us. So, Dr. Rajeev, could you please elaborate on the advantages of giving neoadjuvant chemotherapy in this patient?
The studies are detailedly presented with all the speakers. So the one advantage we will come to know that the benefit of neoadjuvant therapy, the patient satisfaction will be there, and pathological complete response, definitely they do well. So this is what I wanted to enlighten.
Dr. Seema,
Yeah.
Dr. Nitin, yeah, I'm audible.
Yeah, you're audible.
Can I comment here?
Great. Yeah. So I have a question for you before I go ahead. So in your clinical practice, what percentage of patients who are breast conserving surgery ineligible and at the presentation and you start them on neoadjuvant chemotherapy, what percentage will convert into an BCS eligible group? What is your, I
So in
mean,
my, it's for me, Dr. Nitin here.
yeah, for you.
So in my practice, only 10 to 15% of patients will want to go for BCS. Not
Okay.
much.
Mhm.
But going to the previous slides, we have two options in this case, neoadjuvant chemotherapy or surgery. Both are there with us. If the patient wants to go for breast conservation surgery, depending on the size of the lump as well as the ratio of the breast size, we can consider for neoadjuvant chemotherapy if patient is willing for breast conservation surgery. If not, then MRM can be done straight away and then adjuvant treatment can be planned in this case.
Okay. Dr. Suresh, in your clinical practice, what percentage of patients do convert from BCS ineligible to BCS eligible after neoadjuvant chemotherapy?
Same here because the presentation is quite late in our setup also. So there are very few patients that we are, for that we are offering the neoadjuvant chemotherapy.
Okay. Dr. Rajeev, you said you will go ahead with neoadjuvant chemotherapy first. What regime you will choose for this patient?
As it is a HER2 positive, I will go with the dual HER2 blocker.
Okay.
Trastuzumab with pertuzumab with chemotherapy.
Okay. So why do you want to add pertuzumab in this patient who's having a 4 centimeter tumor and only a single node which is mobile?
Looking at the data, if it is more than 2 centimeters, the benefit was there with the more than 2 centimeter size. So that's why I wanted to add with the data.
Okay. So in your clinical practice, do you see that majority of patients can afford pertuzumab? I mean,
No.
my practice,
I work in a government institution.
trastuzumab are also very few, only 30 to 40%.
I work in a government institution, absolutely.
Yeah.
So we don't have that. We generally practice in our clinical setup is trastuzumab with chemotherapy.
So these are the advantages of undergoing neoadjuvant chemotherapy. We can look at early assessment of the effect of systemic therapies. We can get prognostic information in patients who achieve pathological CR. And the most important factor of reason for giving neoadjuvant chemotherapy is that we can tailor the treatment, particularly in those patients who has residual disease post neoadjuvant chemotherapy. And we have enough data regarding this. The CREATE-X trial in the triple negative breast cancer and the Catherine trial in the HER2 positive subtype of breast cancer. So, Dr. Rajeev, do you think that there is a difference between trastuzumab based and non-trastuzumab based regime in terms of pathological CR rate when we give them as neoadjuvant chemotherapy?
Definitely, madam. If you are not using HER2 targeted, the response rates will be lesser. So there is a good difference.
Okay. So, Dr. Nidhi, can I ask you the next question? So, does the achievement of pathological CR correlate with improved survival? And how does this correlation differs between different subtypes of breast cancer?
It does differ because it prognosticate the value is there, and whenever there is a pathological CR, it translates into a better survival.
Okay. So is it same across the different subtypes, or it is the
No, it isn't.
is much
It
better
isn't. It
or
depends
much
upon the
stronger in
yeah.
certain group and lesser in different subgroups?
The correlation is better with the luminal type.
Okay. Luminal type, that means for HER2 positive, the correlation between achievement of PATH CR and improved outcome is better.
Yeah.
Okay. So Dr. Amol has also joined us. Amol, can you hear me? Hello,
Yes, I
Amol,
can
are you
hear.
there?
Can you hear me?
Yeah. So Amol, so what
Yeah,
is
I'm
your
there.
take on the, yeah,
Am I audible?
yeah, okay. So does the achievement of pathological
Am I
CR
audible?
rate, you are audible. So my question to you is that does the achievement of pathological CR rate
Yeah.
correlate with improved survival? And how does it differ between different subtypes of breast cancer?
No, there is no data. There is no data which says that the pathological CR achievement will lead to improvement of OS. So it does not improve the overall survival. What it improves is probably an event survival, but not the OS.
Okay. So in which
So
subtype the correlation is
chasing a
better?
pathological CR is chasing a pathological CR probably in the based on the available data in an HER2 positive and ER/PR negative subtype. If you achieve a pathological CR, you may have a better correlation. But again, in that subset also, there is no OS benefit as per the current available data.
Okay, great. So this is the meta-analysis which looked at the outcome of HER2 positive breast cancer, and it also looked at the what is the hazard rate for event-free survival for pathological CR versus no pathological CR and receipt of HER2 targeted therapy. As Dr. Rajeev has also mentioned earlier that he would like to give that patient dual HER2 targeted therapy. So if you look at this forest plot, patient who received HER2 targeted therapy, definitely they had a better chance of achieving PET CR, and in those subgroup of patients, those who achieve PET CR, probably they have a better chance of improved event-free survival compared to those who did not receive HER2 targeted therapy. Those still have achieved pathological CR. Similarly, the effect of the advantage of achieving PET CR was greater in subgroup of patients who are ER/PR negative and HER2 positive, as shown by this blue line. The hazard rate here was close to 0.3, and the advantage was less in patients who are ER/PR positive and HER2 positive, that means triple positive, though they also achieved PET CR, but there the hazard rate was 0.50. So, as elaborated by my panelist, this graph shows the relationship between PET CR and the event-free survival. That means this blue line represents the patient who achieved pathological CR, and the orange one are the ones who did not achieve PET CR. Those who achieve PET CR, they have a better event-free survival compared to those who did not achieve pathological CR. This is across all subtypes. When we divided these patients into different subtypes of breast cancer, the correlation was best in triple negative breast cancer. So there's a clear separation of curves between those who achieve PET CR versus those who did not achieve pathological CR. This correlation was also stronger in patients who were HER2 positive, but there is some overlap in these two curves. It was less as compared to triple negative breast cancer. So this is the graph which Dr. Amol was alluding to. This is also a meta-analysis published in year 2014, and it shows that if we have an improvement in pathological CR, suppose we have treatment A versus treatment B, if treatment A achieved PET CR of 70% and treatment B achieved PET CR of 50%, that increment in pathological CR does not lead to improvement in event-free survival. This is what these graphs are representing. That you can see these dots are all over. There is no correlation between increase in PET CR versus increase in event-free survival or the overall survival. So getting a PET CR rate has an prognostic value, but increment in pathological CR does not mean that it will improve event-free survival or overall survival, either of the two. So, next question to the medical oncologist per se. What is the role of adjuvant therapy in patient who achieve pathological CR? Do you think that we should go ahead with adjuvant therapy, or we can omit adjuvant therapy in patient who achieve pathological CR? Do we have any data on that? Dr. Amol, do you like to take this question? So, patient who achieve pathological CR, can we omit adjuvant chemotherapy further? Any data on that? I think Amol has logged out again. Dr. Rajeev, would you like to take up this question? Any data on this? Can we avoid adjuvant chemotherapy?
As per the planned therapy, whatever we are planning, we have to complete the therapy. But as of now, except for the Catherine study and createx in triple negative, so there is a data is not so mature for giving chemotherapy for the complete CR, pathological complete CR. So what is planned before the neoadjuvant, we have to complete it. That's what.
Okay. Dr. Nidhi, if we look at our first patient again, that's a 4 centimeter tumor, and suppose that surgeons have gone ahead and have done the MRM upfront, would you consider giving radiation therapy to her? And she has one
Um,
node positive, 4 centimeter tumor, one node positive, upfront MRM done. Would you consider giving her radiation therapy post surgery?
positivity is there, so there is data to show that whenever there is nodal positivity come, so it is
So any
recommended.
node positivity, you will adjuvant therapy, radiation therapy. So
Pardon?
one more sorry. So what is your take on the fast trial that now? Hello, am I audible?
Hello.
Now,
Hello, am I audible?
Yes.
Yeah. So what is your take on the fast trial that nowadays we can finish radiation in 5 settings? No need to give those 15 settings. Do you think it is good enough? The data is good enough to change the routine practice, and we can give really hypofractionated
Yes, it
radiation?
is possible, but the data is more convincing in the intact breast as compared to the post-op MRM cases. So it is more convincing.
Okay. You have muted yourself.
No, it is. I haven't muted. Am I not audible?
Yeah.
yeah, audible.
Yeah. Now you're audible. Continue now.
Yeah. So hypofractionated RT is more convincing in cases of the intact breast.
Okay. So have you adopted this practice in your clinical this past trial in your clinical practice? Have you started giving 5 days radiation?
We
And
are
in which
we are
subgroup you
do,
are considering
we
this?
are using hypofractionated RT in all the intact breast cases these days.
Okay. So does it vary with the node positivity?
Yes.
Suppose a patient has
Yes,
undergone
in
BCS, she has
very
6 node positive.
high nodal burden, still the data is ambiguous because if it is more than 4 node or very heavy nodal burden is there, still the data is not very convincing for hypofractionated RT, but it is definitely there for the lower nodal burden. In higher nodal burden, still the conventional fractionation has a better result. It is more convincing.
Okay, thank you. Dr. Shailesh has joined us. Dr. Shailesh, so my question to you is, do you think that we can omit adjuvant chemotherapy in a breast cancer patient who has achieved pathological CR after neoadjuvant chemotherapy?
So, as Dr. Rajiv has already told, that the planned treatment should not be changed. For example, if you have an HER2 positive patient and patient has achieved the PAT-CR, no need to change. You can continue with trastuzumab. In a triple negative, the patient has received PAT-CR, the patient has completed the treatment. If the patient requires adjuvant RT, maybe it can be given and nothing else.
Okay. This do not mean data, but this is definitely hypothesis generating. This is the data from a meta-analysis of 52 trials where close to 28,000 patients were included, and this was recently published. So this data looked at the impact of adjuvant chemotherapy on the relationship between PAT-CR and the event-free survival. So this blue line represents the patient who achieved PAT-CR, and this orange line represents the patient who did not achieve PAT-CR and who had received adjuvant chemotherapy versus those who did not receive adjuvant chemotherapy. So we are not to be using routine clinical practice, but there is probably some data in patients who achieve pathological CR. Probably we can avoid uh, further adjuvant chemotherapy, and 2 trials in HER2 positive setting are already underway. So we have to wait for those results to apply this in the routine clinical practice. So does tumor size was 2 centimeter, as in the case we have, and node negative, then what do you consider first? Neoadjuvant chemotherapy or surgery? Dr. Suresh, Dr. Nitin.
Can you
And
repeat
patient
the
says,
answer,
doctor, you have
please?
to disturb me. What is best?
Actually,
Pardon me?
the voice is not clear. Can you repeat the question, madam?
Question is, in the same patient, if the tumor size was 2 centimeter, clinically node negative, what would you consider first, surgery or neoadjuvant chemotherapy? And patient says, doctor, you have to decide for me. I not
So,
decide. You tell me what is best.
I prefer surgery, ma'am.
I do agree
Okay,
with
I
Dr.
also prefer.
Suresh that this case we
Yeah.
should consider for surgery straight, and depending on the final histopathology, adjuvant treatment should be planned.
Yeah.
Yeah. Dr. Rajeev and Dr. Shailesh, quickly, what would be your take?
So I feel that any patient who requires adjuvant chemotherapy is actually a candidate for a new adjuvant chemotherapy. So it all depends on the HER2 and the hormone status. So if the patient, for example, is a
Yeah.
triple negative patient or an HER2 positive patient, I would still, with the 2 centimeter, would like to go for chemotherapy first, followed by surgery, even if it is 2 centimeter and node negative.
Okay. Dr.
So,
Rajeev, what
so
would you do?
I agree with Shailesh, sir. But as of now, the evidence is for more than 2 centimeters. So if it is below 2 centimeter, it is difficult to convince with the evidence. The patient is preferring, definitely we can go with a high risk group, R2 positive, triple negative. It is always go with the neoadjuvant. So we can see the pathological response. Even in the last meta-analysis they have done with the recent 8 studies, they have shown that the patient who have PCR, they are the better candidate. They have the, of course, we cannot expect a OS in a short period, especially in adjuvant breast cancers. So they are the subset, they do well. That's what I.
We
I
should
want to
look at it as
comment
a
on this.
systemic disease.
I want to put a comment on this. Hello.
Yeah.
The only problem that a surgeon will face once there is a pathological CR in a 2 centimeter lesion is to relocate the lesion and do a good X surgery after that. But the protocol will say that you give a neoadjuvant chemotherapy and then you operate the case.
So
If the patient is
normally
willing, if the patient is willing for breast conservation surgery, then to locate the lesion after pathological CR is very difficult.
so normally we put a clip, sir, there. We
I
put a
do
clip.
agree with that. We put the clip there, but the recurrence rate at that site in the literature is from 4 to 32%. And even the event-free survival or overall survival doesn't change in this 2
yes,
centimeter lesion size.
yes, yes, I am agree with
Result remains the same.
that. Yes, yes,
The
result remains.
event-free
So why?
survival and overall survival remains the same.
Yes.
We do agree with the overall survival, sir. The overall survival, definitely there is no benefit.
Moreover,
no
the
benefit
exact
between
pathology
any.
will not be known. Once we give NACT in such early lesions, I mean, the exact pathology, the nodal sampling and all, they would not be known.
Yes.
In that case, the protocol will be totally different. If a 2 centimeter lesion with no clinical palpable node, we have to do an ultrasound of the axilla and see if their nodes are there or not and do a true cut biopsy or FNAC from the axillary node if it is significant.
I agree.
That is true. So upfront surgery for such cases is mandated.
Yeah.
Ma'am, sorry for the
So
interruption.
as most of the panelists, yeah.
Ma'am, sorry
So
for the
as most of the
interruption.
panelists agree,
But can
yeah,
you
please.
put the slides on full screen mode?
Yeah. So this is the last slide actually.
Thank you, ma'am.
Yeah. So as most of the panelists agree, this patient underwent upfront surgery and the patient chose to undergo MRM rather than breast conserving surgery because of her logistic issues. And the final HPR was, it was a grade 3 tumor. Tumor size was 1.5 centimeter. All nodes were negative and IHCs were ERPR negative 1 to 3 plus. What adjuvant treatment you would consider? Dr. Raj, Dr. Shailesh.
Shorter.
Shorter. And what chemotherapy?
ER positive. ER positive.
ER negative, PR negative, HER2
It's a
3
Yeah,
plus.
I think, is it negative? Oh, sorry, I was in a mobile. I couldn't make it.
Yeah, so it is negative. ER, PR negative, HER2 3 plus. What adjuvant you would give her?
Young patient, maybe
Definitely.
TCH or 4AC followed by taxanes plus trastuzumab with maintenance.
Okay. Dr. Rajeev?
Yes, madam. More than 1.5 centimeter. The same patient, it is ERPR negative now.
Yes, ERPR negative,
So
HER2 3.
grade 3. So definitely anti-HER2 with the trastuzumab with chemotherapy, whichever
So what
is.
chemotherapy would you use? Do you really want to give her anthracyclines or can we give her some other protocol?
In our
Can
institution,
anthracycline
we do practice anthracycline. TCH is also a better option.
Yeah. So another option that we can give her is the APT trial, where we can give her weekly Pacli with trastuzumab followed by trastuzumab maintenance. So 12 cycles of weekly Pacli trastuzumab. And in that app trial, the majority of the patient has tumor size less than 2 centimeter, and only 10% has tumor size between 2 to 3 centimeters. So she is fitting into that criteria. TCH is also a reasonable option for her. But in such patient, I would definitely avoid giving anthracyclines and to give, I would like to avoid cardiac toxicity from the anthracyclines.
Dr. Seema,
So I think this was the last slide. And
you were saying
yeah,
that because
please
of
go
the
ahead.
logistic reasons, she opted for MRM. So, in such cases, when the tumor is so small, even APBI, I mean, intra-op implant can be done and she can be taken care of because this was an ideal case for BCS. So, I just want to put in a word by stating that such cases should be counseled for intra-op treatment of radiation also. So,
Okay.
within the
So,
same setting of anesthesia, this could have been,
yes,
I
yes,
mean,
I
such
agree with
cases, they may be taken up for interstitial implant, and within a week's time, the treatment would be over.
Yeah,
Yes,
I agree with you
I do
completely,
agree.
Dr. on this. And would you consider giving APBI in HER2 3 plus also, or would you consider only for ERPR positive, really good risk category type of patients?
I don't think that would take a bearing on the radiation. The local treatment would not change, especially
Okay,
in such small tumors. It won't make a bearing on the decision making.
okay, okay. Thank you so much for pointing out that. So I think I have overshoot my time. I would like to thank all the panelists for the wonderful
Thank you so
discussion.
much.
Thank you,
And I
ma'am.
will,
Thank you very much.
yeah, thank you so much.
Thank
And
you.
thank you,
Thank you.
Dr. Sandeep.
Thank you, everyone.
Thank you so